Hello, it's Stacy. So I'm going to go ahead and start on the nutrition lectures. I know I've said a million times that I'm going to go to pancreas and biliary tree, but I'm still waiting on one lecture to get uploaded. And then once it is, I'll finish that out. So I'll go ahead and put this on my Google Drive. Just know that the radiology lecture and all of biliary tree is not complete. And I put under construction in that section. So as always, it is free to subscribe and you can go ahead and subscribe to my channel. So if any new videos come out, you'll be the first to know. I may also put some derm videos on there today as well, or at least get those started. So let's get started on nutrition. So this is going to go over the 3 lectures that you're going to have next week for nutrition, but you can already get a jump on it if you want. It's McGill's, Zieren's, and Babos's lectures. Okay, so let's look at malnutrition. So there is protein energy malnutrition, which there are primary and secondary sources. Primary sources are going to be socioeconomic causes. So they're not in an area that they can get food or they can't afford it. Secondary causes is that they have increased requirements and they're not meeting those requirements. So there are 2 different things that you need to look at: kwashiorkor and marasmus. And this would be like high yield, star. Make sure that you know for more than one lecture. So kwashiorkor is going to have inadequate protein. However, they do get good calorie intake. So what's happening here? Let's say that they've got this socioeconomic cause of malnutrition and they are, let's say they can only get rice or only get potatoes. And so they're getting enough calories per day, but potatoes and rice don't have enough protein. And like, let's say that's all they're eating. They're not able to get beans or anything else, no meat, just calories. They can result in this kwashiorkor. However, marasmus is going to think about they're not even getting enough calories. So they're not getting enough protein or calories. So know the difference between those 2. In kwashiorkor, they're going to have increased edema in the lower extremities. So think of like really large legs, big bellies. Marasmus, they're going to have that loss of muscle mass. They're not getting enough calories, so they can't build muscles. They're going to have sub-Q fat, but no edema. So make sure that you know no edema with marasmus, but there's going to be increased edema with kwashiorkor. Their weight is going to be normal in that one. However, in marasmus, they're not building muscle. They're losing fat. So obviously they're going to have weight loss. They're going to have that flaky paint rash and a fatty liver in kwashiorkor, and marasmus, they're going to have dry, thin skin, sparse hair, and diarrhea. I mean, they're not getting nutrients. So they're going to start having all of those like vitamin deficiencies that we'll learn about in a second. Treatment. We want to slowly increase our protein in kwashiorkor. So slow milk to eggs diet. They may need it in G2 for eating. In marasmus, you're going to slowly increase the calories. So why do we want to do this slowly? Because we can get this thing called refeeding syndrome. So refeeding syndrome, there's going to be low phosphate. And if we increase it too fast, we can actually induce a respiratory failure. So they're going to have low phosphate, low potassium, low magnesium, high oxygen, and CO2. So you have to slowly get things back into the diet, or you could end up with this refeeding syndrome. So no big edema, kwashiorkor, no edema, marasmus. Okay, vitamins. Just a little side note that he said was important. I don't think it's like super duper important, but daily kcal requirements by age, 66% of that is going to be a fluid intake requirement. So I don't think that you need to calculate, and I don't think that you need to know every age how many kcals. Like in real life, you'll have a chart, but just know that like it doesn't matter the age, 66% of that's going to be fluids. Fat soluble vitamins are going to be our A, D, E, and K. And so deficiencies in each of these. A is going to be night blindness and immunodeficiency. So we think about eating carrots for vitamin A and we increase our vision. Vitamin D went over a million times. Rickets in kids or osteomalacia in adults. So in kids, look for craniotabes, that's that soft spot on the head, or that rachitic rosary or bony necklace along the sides of the ribs. Vitamin E, it's almost impossible. You'd be low on everything before you ever like got a vitamin E deficiency. But if you do get an overconsumption, you're going to have an increase in bleeding. Vitamin K, if you have a decreased in consumption, you've got a deficiency, then you'll have excess bleeding. Remember about that like warfarin inhibits K. B1 is going to be beriberi deficiency, and B3 will result in pellagra. B12 is going to give us an anemia. And all of these guys that we're talking about right now are absorbed in the duodenum. And just know for like Zieren's lecture, calcium is active in the duodenum, but passive in the jejunum. And I like put stars by this, so I think it might be important. I'm not really sure if it was tested or anything yet, though. Okay, folate deficiency, make sure you absolutely know this. So symptoms wise and signs are going to be a macrocytic anemia. Folate is really important to prevent neural tube defects. That's why that they started putting it in cereals and different foods, because go all the way back to last semester, and without folate, kids like maternal, if without maternal folate, they might get one of those spina bifidas and or other neural tube defects. So it's important for moms or to get folate. And remember, the like neural tube development starts in the first few weeks of life. So the thing is, women may not even know that they're pregnant yet. So they may not be taking folate. So it's really important for like any sexually active female to take folate just in case, to prevent these neural tube defects. And it is in a lot of foods that we eat. So it can also cause palpitations and dyspnea. So what's important to know from this that I put a big star and highlighted? Goat's milk does not contain folate. So here's a practice question. Shirley Sue is a new mom that lives on a goat farm and raises her own vegetables. She wants her kid to have the best and only gives her 1-year-old homegrown vegetable mash and goat's milk. During this routine checkup, what do you even think? Okay, what are you going to notice on a blood smear? What should you be thinking? Oh no, we've got a macrocytic anemia because of folate deficiency. So what do you tell them? Hey, like, let's get, you don't have to say like, stop drinking goat's milk. You can just say we need like to supplement your kid with folate. Okay, iron deficiency, not this type of iron. It's the most common nutritional deficiency in the US. And remember that, it's absorbed in the duodenum. Symptoms in kids is going to be developmental delays. And so they end up doing a little finger stick and checking this at 1 year old. And also it can result in fatigue. In adults, of course, it's going to be different. With kids, it really depends on age. Like you can get a supplemented formula or just supplements, or like I know that they've got like little drops that they could put on their tongue for iron deficiency. Okay, normal growth parameters. I think this is really important to know. So in the first few days of life, they lose about 10% of their birth weight. In 2 weeks, they gain back that 10% and they're at their birth weight. So a new mom or dad might get really concerned and think, my kid's not growing. And maybe I shouldn't breastfeed, but continue breastfeeding. Even with this early weight loss, it's normal. It's okay that they lose weight in the first few days. That's normal. And it's okay that they look like they haven't gained anything by week 2. Um, that's what happened. So in a practice question, I said Jolly Jane recently gave birth to a beautiful baby boy named Charlie a week ago. Charlie weighed 7 pounds at birth, but right now he weighs 6.5 pounds. Jane's currently breastfeeding, but is concerned that he may not get enough milk. Is this weight okay? Should you switch formula? So like quick thought, quick math. If he weighed 10 pounds, 1 pound would be 10%. So 6.5% is a-okay. He is less than 2 weeks old. He has only lost half a pound. Continue breastfeeding. Okay, SIBO is small intestine bacterial overgrowth. We've talked about this a little bit in some of the slides. Symptoms are going to be like excessive fermentation, inflammation, malabsorption, bloating, gas, watery diarrhea, dyspnea, weight loss, flatulence. Associated with short bowel syndrome or chronic pancreatitis and even Crohn's. You're going to have some malabsorption problems like protein, fat, carbs, as well as vitamin B12, A, D, K. Treatment is going to be good hydration, probiotics, avoid high fatty foods, boiled starches, and cereal, and sort of go to the brat diet. So you're asking, okay, what in the world does brat mean? Bananas, rice, applesauce, toast. SBS, short bowel syndrome, that we had just seen on this slide, is a loss of a large amount of intestinal absorptive surface area. So you're wondering, okay, how did I lose it? Well, if you think about like even like Crohn's, you've got a loss of normal structure. Or let's say you had a big surgery, let's say you had like a small bowel obstruction, they took a section of the bowel away. If you have lost anything less than 2 meters of small bowel is okay. Anything greater than that can result in a short bowel syndrome. So if we're left with less than 2 meters of small bowel, it's going to result in the short bowel syndrome. Malabsorption, we've got water, electrolytes, vitamin A, D, E, K, really all the B vitamins, iron, calcium, protein, fatty acids. Our small bowel does a lot. So in surgery, it's important to like sort of measure this and know we don't want to like give our patient short bowel syndrome. So it's important to leave more than 2 meters of small bowel. Also know that like gastric bypass surgery could result in this, and it can result in a dumping syndrome where you're getting rid of all of these electrolytes. Drug interactions. I thought this was pretty important. It's pretty much rote memorization, but metformin can decrease B12, PPIs and H2 blockers decrease that gastric acid. I mean, that is their job. So think about, okay, if it's decreasing gastric acid, things that gastric acid breaks down, like proteins are going to have like a harder time to be absorbed. Chlormethanol is going to have, there'll be an increase in iron, but decrease in B12. Diuretics, depending on the one, will change absorption of magnesium, calcium, and potassium. Cholestyramine decreases vitamin A, D, E, and K, B12, folate, and calcium absorption. And that's used to treat gallstones. Antibiotics can decrease minerals and decrease our good flora. Remember, we had talked about if it decreases too much of good flora, it can possibly create a bad environment and create C. diff. And then MTX decreases folic acid. So fiber. So there's going to be soluble and insoluble forms of fiber. Soluble things are going to be slimy and slow. They dissolve in water. So slimy things, oats, apples, pears, carrots, beans, and psyllium. Soluble fibers are good because they decrease cholesterol and blood sugar. Insoluble fibers are sort of, I think of more of like the harder things. So whole grains, broccoli, cabbage, tomatoes, fruit, veggie, and veggie skins. They don't dissolve in in water, and they help bulk up our stool. Okay, so this is the pharmacology lecture. Looks like my typical Pharm slides. So water soluble vitamins are going to be our B vitamins. So B1, um, thiamine helps with carb metabolism. It combines with adenosine triphosphate to form thiamine pyrophosphate. Chronic alcohol use can decrease our thiamine. So remember that we give B1 first. So you give thiamine before that you give blood sugar, or before you give like D5. B1 deficiency can result in peripheral neuropathy, cardiomyopathy, and sort of go to this Wernicke's encephalopathy to Korsakoff syndrome. So remember, Wernicke's encephalopathy has that like can, so confusion, ataxia, and neuropathy that goes on to Korsakoff, which results in anterior grade amnesia. B3 niacin deficiency, remember we can get that, we can get a rash, and then it has a lipid lowering mechanism. If we're giving too much, if we give a patient niacin, and some people that used to give this for to lower cholesterol, it can result in flushing, nausea, vomiting, or itching. But really, like, no, niacin goes with flushing. B12, a deficiency can cause pernicious anemia or gastric disease, and it can be caused by use of PPI. So we're decreasing our gastric, or PPI or H2 antagonists. So we're decreasing gastrin, and so we're not able to absorb B12. I would know that vitamin K promotes liver synthesis of clotting factors 2, 7, 9, and 10, and a deficiency results in bleeding. Phentermine in obesity, I would know that it increases norepi release in the hypothalamus, and it reduces appetite. Don't give to people with heart disease. Don't give to people with anxiety, hypertension, and insomnia. A thing about phentermine that I think is sort of interesting, it was combined with another drug in the 80s and 90s, and it was called fen-phen. And it actually like caused major heart problems and killed a lot of actual like people in the US. And so they took it off the market, but they kept half of the drug. And so they took the half that they said caused the most like heart problems and heart failure, but like they kept the other part, and you still don't want to give in heart patients because it could cause maybe even an arrhythmia or increase like tachycardia. So I don't know, I find it interesting. Okay, so that is it for nutrition, and I promise I will have the biliary stuff up and radiology up as soon as those lectures become available. Thanks.